So my name is Zsofia, I'm the TP at Ashford and St. Peter's, and I thought I'm going to share a case with you we had last year in August. So I'll tell you a little bit about an overview what's happened exactly. That was last year in August 2019. There was a 26-year-old female who attended for a scheduled diagnostic laparoscopic surgery under GA for rule-out endometriosis. So that was a surgery planned for our satellite site in Ashford, where we got a daycare surgery. But the procedure resulted, unfortunately, with a catastrophic massive hemorrhage at the start of the procedure. The patient became peri-arrest before the ambulance could take her over to St. Peter's, and unfortunately, they had to do a laparotomy on site in attempt to hemorrhagic control. Can I have my next slide? So a little bit about Ashford Hospital site. We are 11.3 miles from St. Peter's, and we got M25 next to us. We are next to Heathrow as well. So the traffic is very unpredictable. There is no guaranteed delivery times for blood components to the sites. There was no massive hemorrhage on Ashford site for about 7 years at that time. The majority of planned surgeries in Ashford are day cases, orthopedic surgery. We have some rehab sites in there, ophthalmology, outpatient services. On the site, we have a small satellite fridge where we have 2 units of O neg and 2 units of O positive. And we have no blood transfusion laboratory on site. We only have small pathology reception next to the satellite fridge. Can I have my next slide? So the chain of events, you can guess it. There was a lots of delay. So let's start with the group and save. There was no historical group and save done for laparoscopic minor surgeries at the time. The urgent group and save arrived before the massive hemorrhage call. 2 samples came to the blood bank to St. Peter's. 1 had to be rejected. So before the double two activation being done for massive hemorrhage, 2 units of O negative has been taken from the satellite fridge. But at the time, the clinicians perceived that they have to ask for permission from the blood bank to take the O pause. So also the specimen reception manager refused to release the O pause unit at the time because she referred to the guidelines kind of correctly that it's a childbearing age female, so they should not take the O positive out from the fridge at all. So at 12 o'clock, around 12 o'clock, the massive hemorrhage triggered by a double two. There was no follow-up call to the blood bank, so they had no idea where is the patient. Is it St. Peter? Is it Ashford? At 12:30, the theater matron went over from St. Peter's to Ashford, confirming a controlled bleed on the site. And around just before 1 o'clock, 4 units of red blood cells issued and collected by transport taken over to Ashford, but there was no FFP told out at this time. So around 1 o'clock came a request that they will need FFPs. That's the time when the blood bank started to thaw them out. So if you look at the timing from 12 o'clock till 1 o'clock, it was already 1 hour in between delay FFP thawing out. That product arrived to Ashford at 2 o'clock. So basically there was 2 hours before FFP has been started over the patient. So further products being issued and arrived while the patient being taken over to St. Peter's. FFP needed more to ITU while the patient arrived to St. Peter's, but there was no other tour. We only had 1 tour, so we only could work with 1 tour at the time. This caused delays again. So tax did not come back completely due to the chaos around. There was no documentation of the cool boxes found at all. Can we have the next slide? So as you see, we had to kind of put together the mosaics exactly what's happened. It was a long investigation and looking for the root causes. So for the laparoscopic surgeries at the time, there was no need for group and save samples at all. There was conversation even before that if the emergency blood provision is enough on the site. And we find out there was lots of training issues with activation of the massive hemorrhage protocol, with the sample requirements of group and save, the correct labeling of the samples, which should have been very simple, emergency blood locations and how to use it and which one to pick out in emergencies, the importance of the documentation for transfusion chart. And we had the site nurse practitioner's responsibility, which came out to light that they do hold the bleep and they do respond to massive hemorrhages, but because their day job is in outpatient clinics, they had no idea what is their role exactly in the massive hemorrhage protocol. From the blood bank side, they should have been much more prompt with the reaction for the urgent sample coming from Ashford and called the ward before, but unfortunately they did not know where is the patient. The actions should have been taken once controlled status, and once the uncontrolled status is known, and pack up the products much more quicker. So there was no massive hemorrhage drill on Ashford side for years, because what's happened, Ashford and St. Peter kind of treated as one site at the time. So St. Peter had the massive hemorrhage drill, but nobody ever thought we're going to have a massive hemorrhage at Ashford site. We only have one tour available. That caused delays, and also the transporting of the samples and the blood from Ashford to St. Peter and vice versa. We had no clear process. There is no robust enough system in place. The urgent sample, for example, had to go onto a hopper bus, which has been used by public as well at the time because there was no driver available. There was no correct equipment and trained staff in place at Ashford to do any kind of laparotomies at all, and there was a massive communication failure between the sites. Can I have the next slide? So what has been done since? Obviously, full trust investigation has been taken place. So the surgical transfusion in blood transfusion policy has been changed now. So all laparoscopic surgeries need a historic plus the current group and safe sample. The reason for that, pre-op, when they're preparing the patients, they don't know if the patient's surgery is going to take place in St. Peter or Ashford. Training has been carried out massively for daycare surgery staff, theater staff, the site practitioners, porters, how to reactivate the massive hemorrhage and what is their role in there, where to locate the emergency blood, use of the anti-D if they will take the O-post blood for a childbearing age female, sample taking labeling requirements to avoid any kind of delays when the massive hemorrhage has been activated. The specimen reception staff at Ashford, we included the actions and responsibilities for them, what to do if there is a massive hemorrhage. They usually kind of police and manage the blood fridge at the Ashford site. At the time of the massive hemorrhage, they felt they have the authority to question how much blood has been taken. This has been addressed, and we went through everything with them. What is their role if there is a protocol activated? There was an anesthetist meeting as well, and it came to light they had a lack of knowledge of the massive hemorrhage process activation and the location of the emergency blood, where they can find it. The switchboard has been asked to add the contact number to every bleep when massive hemorrhage protocol activated, so the wards can be contacted by the blood bank as well if it's needed. And then we put laminated posters with satellite fridge access instructions to daycare surgeries, main theaters to Ashford, and massive hemorrhage flow charts has been placed on resus trolleys as well. There was a query to move the satellite fridge from level 3 to 2 to main theater, but unfortunately there is no out-of-hours access at the moment. At the transportation of samples and blood components reviewed by the transport manager, we had meetings with them a few times. There is still no 100% clear process what we're going to do if there is another massive hemorrhage on Ashford side. So this has been escalated to exec levels and safety and quality meetings as well. Still no guaranteed delivery times. Unfortunately, we're trying to work out solution for that at the moment. The massive hemorrhage heal has been done in 2020 February, and we experienced the same delays at the time when we done the massive hemorrhage protocol. So we would like to repeat that, but until the transport issue has been sorted out, we are not sure that we would have a different outcome. So from the blood bank side, response to urgent samples and the timely issues of the products at the massive hemorrhage discussed with all the BMSs and highlighted the best practice to take action straight and ask questions freely. So response to massive hemorrhage trigger at Ashford needs to be prompt and much more quicker. So if you see the next slide, we changed the massive hemorrhage protocol specifically for Ashford side, and we made it clear that every massive hemorrhage needs to be treated as an uncontrolled massive hemorrhage until we have a robust transport services in place. So just the last slide I've got, just to give you a quick update on the patient. Unfortunately, the patient surgery went ahead. She had an emergency laparotomy at the site on Ashford. She then shipped over to St. Peter's with a packed abdomen, with an open abdomen. They taken her back on the same day to the theater to repair of the iliac artery laceration and the repair of left common iliac vein inferior carva injury, and they not closed her again until the 25th of August. It was a very traumatic experience for her. Later, the patient has been treated for lots of different things, from SIRS to sepsis syndrome, and they had to start her on NOAC as well. Fortunately, they discharged her on the 13th of September, but she suffered lots of other issues since, and she's still not back to work. It's affected her whole life. She's got intermittent speech and concentration problems as well, and poor sleep, and also she's a teacher, so it's affected her whole life basically.